Good morning, everybody, and welcome to the National Voices Annual Conference 2023, which this year, as hopefully people are all aware, focuses on a topic which we know really matters deeply to people who use health and social care services, and that's primary care, the very front door to all of our NHS services. So we know that primary care has been coming under increasing pressure for many years. And in recent times, we've seen this starting to affect satisfaction levels amongst the public. At the same time, we know that professionals in primary care are working harder than ever to provide the care to people who need it. So never has there been a time when patients, people who use services, the public, communities, professionals, all of us, we need to come together and collaborate to find new ways of doing things to improve access, to improve the quality of care, and to improve the overall experience and make care more sustainable. So that's going to be our topic for today. We're a fair bit to cover, but I'm looking forward to it. For those of you who don't know me, I'm Jacob Lant, and I'm the new Chief Exec at National Voices. I've been in post now for just under 2 months, so I can't really take any credit for this agenda or the fabulous array of speakers we've pulled together for you today. That's all down to the wonderful National Voices team who've been busy beavering away behind the scenes. But they have asked me to chair the day, and that's a task that I can do, and so I'm delighted to help. Just to cover briefly on the agenda, we are going to be looking at 3 significant projects National Voices have been working on in primary care. The first piece is a vision for the future of primary care, which we have been producing with our 200 members, our lived experience partners, and key stakeholders from across the primary care profession. And so that will be our first session. Later on, we'll be talking about communications in primary care, in particular, how we can improve communication and accessibility of communication to put choice, personalisation, and equity at the heart of primary care. In the afternoon, we will have a session looking at multidisciplinary teams and how that changing setup in primary care can help us achieve joined up, person-centred and equitable care. We also, at 1:30 today, so just after the lunch break, we have a session with Dr. Claire Fuller, who's Chief Executive at Surrey Heartlands ICS and author of last year's Fuller Stocktake, who will be interviewed by our tireless and patient safety champion and health editor at the Sunday Times, Sean Linton. So I'm sure that session will be definitely one to watch, and I'm looking forward to that. We have over 350 people registered to attend today's conference, which is absolutely fantastic. But that does mean we have to stick to a few housekeeping rules to help us manage the day. So I'm going to run through those now if I can quickly. Firstly, to say, can we please keep everybody on mute? With 350 people attending, it's difficult to manage the conversation. So we're asking attendees to stay on mute, but please turn your cameras on if you are able to. It's certainly nice as a speaker to be able to see other people on the other side of the screen. So if you're able to keep your cameras on. Each session will have a Q&A at the end, and we'll be taking questions throughout the session in the chat box at the side of the screen. So please keep your questions rolling in throughout the discussions, and we'll try to get all of them in the Q&A. On accessibility, so a couple of things to mention. We have 2 palantypists joining us today to provide the speech-to-text service. So Joe Norton and Julia Jacobi. So welcome, Joe and Julia, and thank you for providing the speech-to-text service. We also have 2 BSL, so British Sign Language interpreters joining us, Karen Gillespie and Heather Summers. So if you need to pin the BSL interpreters, you can find them in the list. I will be reminding speakers throughout the day to speak clearly and to not go too fast, to help our support team do the best job they can in making our content as accessible as possible. We'll also be making slides available at the end of the event, and we're recording the session, so you'll be able to catch up on anything you miss on YouTube at the end. Lastly, if you have any problems around accessibility or with the technology, please, you can use the chat to ask for some help, or you can email info@nationalvoices.org.uk, and my colleagues Lucy or Aaliyah will help you with any of those technical challenges. Right, that's the housekeeping bit done. And before we move on to our first session, we have a quick exercise that I would like people to take part in to help set the scene. So can I just check, Lucy, are we set up and ready with the Mentimeter activity?
Yep, all good. I can share that now.
Excellent. So if some of you will have used Mentimeter before, others of you won't have, but I'm sure you'll have used something similar at virtual conferences in the past. Basically, there is a, in the chat box at the side, there's a link. If you click on that link, it will open a page where you will be asked 2 questions. And we're going to do the first question first, and then get the answers, and then come to the second question. And what we want you to do is to provide 3 words in answer to these 2 questions. So our first question is, what 3 words would you use to describe your most recent experience of primary care? So we're talking here from a personal point of view. So as a patient, as a carer, as a user, what was your most recent experience of primary care? And you can probably see on the screen, as I can, words rapidly appearing. So we've got positive in the middle. Nice, that's helpful. These are good words. These are, given the pressure on primary care, it's nice to see some positive words coming out. Efficient, quick, resolved. There are some less good ones in there though. So I saw bureaucratic, rushed, confusing, conflicting messages, kind pharmacists. Nice, positive there for pharmacists. Thank you for bringing all of these in. Some really wonderful words in there. I think really showing the genuinely mixed experience people have at the moment. So often very good quality care, but some of the real problems accessing support coming through in those messages. I'm going to give that a couple more seconds just to finish. I think everyone's probably added in their words in now. So we're going to move on in the interest of time to the second question, if we can, Lucy. So our second question, again, we would like 3 words from you to answer this one. What 3 words would you use to describe what you think the future of primary care should look like? So again, if you want to put into the box 3 words on what you think the future should look like. Proactive, I like that, taking center stage, something I can agree with. Accessible, flexible, welcoming, multi-professional, shared decisions, patient-facing, kind. Some really positive things here about what we can aim for in the future. Coordinated, patient-centered, sustainable. I think these are all things that we'll be covering in today's session. So thank you. I hope that that's kind of got the creative juices going this morning, and has helped us set the scene a little bit for how the audience is feeling about the current state of primary care and what we want it to look like for the future. Right then, Lucy, do you want to bring down the word cloud, and we'll move on to our first session. So I'm going to chair this, but I'm not going to do the main presentation. I'll soon hand over to Sarah Sweeney, who is the National Voices Head of Membership and Development. And she'll be talking about the work that National Voices have been doing to create a vision for the future of primary care. And whilst I won't cover the detail, I will talk about just very quickly to say how positive it was to see so many of the themes in our work in this vision picked up by NHS England in the primary care recovery plan last month. There is, of course, a lot more for us to discuss, but I feel that the fact that those two documents are so closely aligned actually feels like policymakers and patients and communities are on a similar page, which is always a good starting point. So we're going to have a presentation from Sarah to talk about the vision. And after Sarah, we'll be joined by a fabulous panel. We've got Becky Baird, who's a senior fellow at the King's Fund. We've got Borshu Borshik, who's head of policy and campaigns at Crohn's and Colitis UK. We have Nick Kay, who's chair of the National Pharmacy Association. Robin Chappell, who is one of our National Voices lived experience partners and who worked closely with us on this particular project. And last but by no means least, we have Rachel Brennan, who's Participation and Progression Director at Groundswell. Each of the speakers will have 5 minutes and then we'll move on to the Q&A. And as I said, please feel free to put your questions in the chat as we go. But for now, I will hand over to Sarah Sweeney to present National Voices' vision for the future of primary care. Sarah.
Thank you so much, Jacob, for the introduction, and lovely to see everyone today. I think Lucy has a little slide that she's going to show that overviews our vision. But really just to say, I'm really pleased to be here with you all today, sharing National Voices' vision for the future of primary care. We began our work on this around 18 months ago. At National Voices, we regularly convene our members, so 200 health and care charities, to advocate for health and care to be more equitable and more person-centred. And every day at National Voices, we hear about ways in which primary care professionals have made a real difference to people living with health conditions and disability. We regularly hear about the kindness of primary care staff and about what a significant difference it makes to people living with health conditions and disability when their needs are well understood and well met by primary care teams in their local neighbourhoods. When things are working well, then people feel listened to, health issues are often picked up really early and nipped in the bud, and people with long-term conditions feel empowered to feel in control of their own lives. However, as Jacob mentioned, in recent years, we've also begun to increasingly hear concerns about challenges, both around access to, but also experience of primary care services. And it won't be a secret to anyone here that we've seen really significant drops in satisfaction with some primary care services in recent years. So analysis of the 2022 British Social Attitude Survey by Nuffield Trust and the King's Fund show that the British public satisfaction with GP services and dentistry are both at an all-time low, so at 35% and 27% respectively. Too often, these conversations about the future of primary care have played out really unhelpfully, with frustrations being targeted at hardworking GPs, dentists, pharmacists, and the wider primary care team. Yet many of the primary care team are working much harder now than ever before. Take just general practice as an example, then we know that GP growth has stagnated for many years and fewer doctors are now looking after greater numbers of people. So while members of the public report it's hard to get an appointment, we know that paradoxically, appointment levels are seeing record highs. And so it's our opinion that the current state of play for primary care services isn't working for patients or for the primary care workforce. And so we find ourselves at a crossroads moment. Our members, many of whom are with us today, have really extensive networks made up of the people who need and use primary care services the most, people living with long-term health conditions, disabled people, and those from communities experiencing inequalities. And so last year, I sat down and started to comb through insights gathered from our members in recent years and began to identify some kind of key patterns of feedback that people felt across conditions and communities would make a significant difference. We then spent spring of this year testing these with key and respected stakeholders in primary care to see where there was an appetite and buy-in for cross-system action. Now, the proposals we put forward were a real mixture. Some of them were things that could happen like here, now, tomorrow, that would make a big change to patients on the ground, but also some of them are much longer term actions that we recognise require much more investment, both in terms of an expansion of the primary care workforce, but also in terms of funding. And really, it's my pleasure to share with you the 9 key actions in our vision for change today. I'm really pleased to share as well that over 50 leading health and care charities have signed up as co-signatories to this vision. So hopefully that gives you a bit of an indication as to the appetite for change around these areas. I think given the first word cloud there and everyone's experiences more generally, you won't be surprised that we start with access. We heard that many people across the country feel like they're falling at the first hurdle when accessing primary care, that it can often feel hard to get an appointment, much less one that suits an individual's life, their work, their current commitments, the type of appointment that suits them best. We heard how frustrating it can feel for people to phone repeatedly and listen through long voicemail messages, or to repeat information about their long-term condition in detail every time they fill out an online consultation form. And so first and foremost, we want to call for a revamp of access and triage for primary care, putting choice and personalisation at the centre. We really welcome the commitments that Jacob mentioned set out within the primary care recovery plan, the commitments to tackle the 8 AM rush and also reduce the number of people struggling to contact their practice. We also believe that people must be given meaningful choices about how and when to access primary care. And we think that this can be achieved by investing in expanding and empowering the front of house team, and also by investing in improved website and telephone system models, particularly websites that were rolled out quite quickly during the pandemic when we were forced to more of a digital approach to health and care. We'd love to see those revised in a way to see that they're kind of really truly person-centred and developed in close conversation with people who use health and care services most often. We think that there's quite a lot that we can learn from businesses, both big and small, who are personalising their customer experience in dynamic ways, and we'd love to see that learning kind of come across to the primary care team as well. Secondly, we heard about the significant challenges many people are having in communicating with their primary care teams, and so we're calling for a modernisation and a revamp of communications, putting choice, personalisation and equity at the heart. We believe that primary care services should communicate with people in a way that suits to them, and that everyone should be able to choose how, where and when they receive communications. Now, this feels particularly urgent for deaf people, for people with low or no literacy, people who don't speak English fluently, people with memory loss, and many other people we've spoken to recently who've got specific communication needs that often aren't being met very well within primary care services. As just one example, our member Sign Health found that 67% of deaf people still have no accessible way of contacting their GP, and we feel this is just totally unacceptable. We think to solve this, we need to really invest in improved systems to record and respond to communication needs. We need to invest in better training and support for staff around this. We need to invest in improved awareness within the public around rights to inclusive communication, as well as stronger accountability where communication needs aren't met. And not only would this make a significant difference for people with specific communication needs, but it would make things better for all of us in the way that we communicate with primary care services. The third thing that we hear is it can often feel confusing and time-consuming to get a diagnosis when people are feeling unwell. And so we're calling for clearer, standardised processes for diagnosis of health conditions, whether for Crohn's and colitis, COPD, secondary breast cancer or other conditions. We believe streamlining processes would make diagnosis easier and quicker for patients and professionals alike. The next thing we hear is that often care can feel disjointed for people with multiple long-term conditions. And so the fourth call we are making is to make support for people with multiple long-term conditions more joined up within primary care. We really welcome wholeheartedly the commitments within the primary care recovery plan to improve the primary and secondary care interface, which we know is a cause of a lot of concern for lots of people who are caught between it. And we're really keen to ensure this takes a patient-centred approach. We also believe it would make a really big difference if services were to embed holistic approaches to reviews of long-term conditions more widely across primary care, and also to ensure pathways speak to one another so that people can access the right treatment in a timely manner. The fifth and perhaps more controversial thing that we're calling for, given we know that there's quite significant workforce pressures within primary care at the moment, is to make it easier to book longer GP appointments. We regularly hear that many patients and GPs find it difficult to cover all the things they need within a 10-minute appointment, and so need to book further appointments. We believe that if it were easier to book longer GP appointments, it would save people multiple visits to GP surgeries and make organising appointments less burdensome on both patients and also on reception teams. And the next significant thing that we hear is just how important it is for people's emotional and social needs to be taken into account within health and care, particularly within primary care. For example, we've heard many instances during the cost of living crisis where people who can't afford some of the healthy food recommended are regularly being told to eat healthily, but actually don't have the tools to do that because of affordability. So we think it's really important for primary care teams to be aware of people's social needs and feel equipped either to support them directly or else to signpost them to someone who can support them if it's not appropriate for primary care. And so our 6th proposal and call is for primary care professionals to be better equipped to meet people's social and emotional needs in holistic ways. And we think this requires greater investment in signposting, social prescribing, peer support, outreach, and more. We know this requires investment in services within the voluntary sector too, but also in systems which make it really easy for primary care professionals across the board to see what is available right here, right now in their neighbourhoods in terms of social and emotional support. The next big thing that we hear about is some of the really significant and long-standing inequalities that exist within primary care itself, both between geographic areas and between groups of people. We heard about the really significant issues many gypsies, travellers, homeless people, asylum seekers and refugees still experience with registering at a GP. A recent report from NACRO found that 40% of GP services surveyed required photo ID and proof of address in order to register as a patient, and for lots of patients this just isn't possible, and it also goes against the NHS England guidance. As health and care charities, we want to see strengthened action on health inequalities, and we believe it is critical that primary care services first and foremost distribute resources according to the level of need, so tackling the inverse care law in primary care, but also taking specific action to address the really kind of long-standing inequalities around wrongfully refused registrations within GPs and within dentists. Ultimately, all of our proposals and visions are wrapped up in our 9th and final call for primary care teams to work more closely in partnership with people and communities. We think this can be achieved by strengthening mechanisms and levers for listening to users of primary care, particularly those who are not well served by the current model. And it seems simple, but redesigning services with diverse groups of people who use them really could revolutionise primary care. We know that some of these proposals you'll have heard before, and some will be new. We know that some of the ideas, like extended appointments, might make some primary care professionals nervous, given the pressures that the profession is under already. We've identified each proposal because we've heard it would make a significant difference to people living with health conditions, disability, and inequality. And we're really pleased to see some of our calls, as Jacob mentioned, already reflected in the Primary Care Recovery Plan and indeed in Labour's plan for primary care. That feels like a big success already. We've held this conference today because we want to share our vision with the wider group and to ask for your help and your support with embedding our vision in practice. Every single one of us in this room today has our own first-hand experiences of using primary care. So today I just ask you to listen to the lived experience of people who speak throughout our sessions, to reflect on your own experience of primary care services, and to consider what your role might be in making what matters to people matter in primary care. We hope our vision provides a strong blueprint for that, but most of all, we're looking forward to going on that journey with you. Thank you.
Thank you, Sarah, and great to see the 9 principles laid out so clearly. Thank you. Right, we're going to move on to our panelists now, and the first up is Becky Baird from the King's Fund. So Becky, would you like to come off mute and come in?
Hello, thanks Jacob. And yeah, thank you. I'm delighted to be able to be here to talk today. My name is Becky Baird. I'm Senior Fellow in Health Policy at the King's Fund, which is a health policy think tank, and to reflect a little bit on the vision and how it might be implemented. As the other speakers have said, primary care across the board is under pressure. Clearly major issues in access to NHS dentistry. GPs are delivering more appointments than ever before, and yet demand is still outstripping the capacity available. And despite satisfaction with the quality of the care received in general practice, it's holding up really strongly. Satisfaction with access is such a huge issue. So there's not much to argue with in the vision that Sarah set out, but I've been asked to talk a little bit about how this might be implemented. So given the time I've got, I wanted to highlight just 3 particular things that I think need to be addressed for this vision to be realised. Firstly, its focus at national and local level. At the fund, I've just launched a new project looking at why, despite 30 years of saying that we, or more than that, that's as long as I've been working in the NHS, of saying we want to shift the balance of care to where people live, to primary and community care, we have spectacularly failed to do so. The percentage of the NHS budget that's spent on primary and community care has been falling compared to the percent spent on acute care, and the focus for politicians and consequently NHS leadership is often on hospitals, waiting lists, operations. If we're going to deliver the vision that National Voices have set out, that's absolutely got to change. That focus needs to be on primary care. Secondly, staff. The absolute elephant in the room at the moment is workforce. A report published by my colleagues at the Fund this week showed that in comparison to other countries internationally, we've got less doctors and nurses per head compared to most of our peers. The numbers of GPs are falling despite the fact we're training more GPs than ever before, and that becomes a vicious cycle. Workloads are really high, and so people find it very hard to stay. Dentists are pulling away from the NHS contract, and pharmacists are also under pressure. And if I'm honest, I don't think we're going to get any more GPs anytime very soon. We need to really focus on retaining the ones we've got and continue to invest in the wider team roles and the wider multidisciplinary team. And these roles help, and they can improve the quality of care for patients, but they take GP time too to manage and to make sure that they're fulfilling the whole role that they can. If this investment in new staff is going to work, we need to do much more to make teams function well. That takes time, skills, headspace, to say nothing of IT and buildings and estates, enough room for people. And I think you're going to hear a lot more about multidisciplinary teams today. And all of that leads me to my final point, which might make me really unpopular, but I'll say it anyway, and that's management. The NHS has one of the lowest management levels compared to other countries, and even less in primary and community care. If we're really serious about improving primary care, we need skilled managers, quality improvement specialists, organisational development specialists, IT specialists and others to give GPs that capacity, that headspace, to give teams and to work with their communities and with their patients who've got the skills to do that kind of work, to really think about how to make change happen. It doesn't happen by accident. Every political party has made statements about access to general practice recently. It looks set to be a battleground for the next election. The temptation is to create soundbite offers, guaranteeing people shorter waits to see a GP, but without being clear about how we'll actually deliver that. And for me, really improving primary care, really improving access to primary care takes a sustained and significant refocusing of NHS resources on primary care, supporting the expansion of the workforce, consistent, coherent engagement with patients and communities, and a continuing and relentless focus on shrinking that gap between demand and capacity. Thank you.
Thank you, Becky, and thank you so much for stressing the point about management. It's a point that I've been raising a lot recently, and interested to look at that in terms of the workforce plan that we expect later in the week, and see where that addresses the gaps we have in management. So thank you. Our next speaker is Borshu Borchik from Crohn's and Colitis. So Borshu, do you want to come in?
Thank you, Jacob. Hello, everyone. My name is Borju. I'm the Head of Policy and Campaigns at Crohn's and Colitis UK. We are a patient charity representing people with inflammatory bowel disease. So we are talking about a group of people, representing a group of people of over 500,000 people across the UK who live with inflammatory bowel disease. For those of you who have never heard of them, they are long-term and very debilitating conditions that doesn't only affect your bowels, but also affects your energy levels, your mental health, your ability to work, socialize. Yet we are hearing from our service audits that we carry out every 2 years that over a quarter of people take over a year to be diagnosed with these conditions, and this is before the pandemic. Unsurprisingly, a lot of them end up in A&E during this time more than once. We have been carrying out a research, talking to people living with these conditions, really trying to understand why these delays occur. And there are multiple reasons. But one key finding from that research was the difference between the length of journeys people take. So we have heard from people who are diagnosed within 10 weeks from the time they present to the GP with sort of key symptoms like diarrhea, blood and stool, etc. others 11 months, others 11 years. And in one instance, we have heard from a woman who has taken 47 years to be diagnosed. You can only imagine how difficult it would be for someone to live in the unknown and not knowing what is wrong with them, not being able to work, not being able to socialize, sitting in front of a toilet, you know, going in every 15 minutes. It really does affect people's life chances. A further global research show that the longer you wait, the more likely you are to have emergency surgery and the more likely you are to run out of treatment options. So, so it has not only have patient consequences on patients, but it also has consequences on the NHS more broadly. One of the reasons this condition is so difficult to diagnose is because there aren't clear guidelines that are clearly set out, that are understandable by the patients for them to be able to self-advocate. Of course, there are guidelines that are written by NICE for primary care for both Crohn's and colitis. However, you know, if you are a patient you know, suffering from the symptoms, you don't know what is wrong with you. It might be inflammatory bowel disease, it might be IBS, it might be bowel cancer, it might be celiac disease. And while each specific condition have their own guidance, there's nothing that brings them together. So we really do support today's call about creating a diagnostic pathway across conditions. These need to be really patient-led and be understood by patients so that they can go and demand, you know, what test needs to be done when, and negotiate those and lead their own care. The second point that I wanted to make is that, of course, like many other long-term conditions, people with Crohn's and colitis have got multiple comorbidities. And with the NHS services, secondary care services being so stretched, they often have to present to primary care when they do have issues, when they have flare-ups. Unfortunately, our primary care services aren't equipped to be able to deal with the complexity that they are presenting with. What we would like to see is a no wrong door approach. So whether the person presents to primary care or secondary care, that is an artificial divide, and they should be able to get that personalized and proactive care wherever they present. Thank you.
Sorry, I managed to stop my video there. Thank you, Borshi. That was brilliant, and thank you. I mean, the reflections on the referral process and the diagnostic pathway. I mean, it's just, we know that for so many people it doesn't work in so many different conditions. So thank you, a really important contribution. Next up, we have Nick Kay, who's chair of the National Pharmacy Association. So hello, Nick.
Hi, Jacob. Thank you. Very, very pleased to be here at such an important organisations conference. So thank you for having me. As you said, I'm a third generation pharmacist. So I have a frontline role in community pharmacies in Cornwall. I work in 2 pharmacies near Falmouth. I'm the interim CEO of Community Pharmacy Cornwall, which represents all the community pharmacists in Cornwall. I have been a partner in GP practice. So I was a GP practice partner for 5 years, which I left last year. And I'm currently, for the last 8 weeks, the chair of the National Pharmacy Association, which represents all independent community pharmacies across all 4 nations of the UK. And I just want to start by saying that we absolutely buy into the National Voices plan, the 9 points. And I think my head was blown only 2 days ago by the definition of primary care by Claire Fuller, one of your other speakers you've got later today, getting us and challenging us to think around primary care being places that you can access without a referral. So is that A&E? Is that, you know, what do we mean by primary care? We, like National Voices report, say that community pharmacy is absolutely a key part of primary care and a key player of primary care. You know, we are proud in community pharmacy that we actually buck the inverse care law on socio-demographic, and community pharmacies are in areas of higher deprivation and lower socio-economic activity. I think also, though, we have to be realistic, and you'll have seen probably the announcement yesterday that 300 Boots stores are closing. Although I don't represent Boots, I think that shows you the pressure and the challenge that the community pharmacy network is under, given a 5-year static funding envelope. Having said that, we do believe that community pharmacy, with the announcement in the primary care recovery plan of increased investment in community pharmacy for 7 common conditions, that when that comes and that's right, we think that's a real step change potentially in moving where people can access care and what community pharmacy can do to close that episode of care so that we don't have to move people to other parts of the system. We believe strongly that community pharmacy represents continuity of care for most patients, especially independent community pharmacies. You have people that have been there for generations, know their families, and know their communities. We also believe that local can influence national. So in Cornwall, we're very proud that we're the only system in England, I think, that allows you to have a consultation with a pharmacist, which is then recorded and is then sent through a system called Pharma Outcomes back to the GP. Over the last 18 months, of 92 pharmacies and 156 pharmacists that are active, we've delivered 8,000 consultations across the footprint of Cornwall. Doesn't sound like a lot, but is showing that even under a pressured system, that we can still access and deliver care. We like the fact as well that community pharmacy is accessible without technology. You can walk in. Most pharmacies, if you're able-bodied, are within a 20-minute walk of everyone in the UK, which I think is as an average, which is really important for accessibility and continuity. I'm really keen to get other people's thoughts and let the panel session go. So we believe community pharmacy is a key player in primary care. We allow access and choice. We need a greater investment, which we're looking forward to getting in the primary care recovery plan. But IT and connectivity back to the wider system is really important. I just want to finish by saying I think the clue is in the title. Community pharmacy serves the people of that community. Thank you, Jake.
Thanks, Nick. And really struck there about actually some of the points about continuity of care, that we have a continuity with our pharmacy. Often we talk about it as seeing the same GP all the time, but actually continuity with your community pharmacist and the fact that you can just walk in and they are more accessible. So there's so much potential, which I think was pulled out in the primary care recovery plan, but lots more to build on. So thank you, Nick. Right, our fourth speaker is Robin. Robin, would you like to come off mute and join the conversation?
Thanks, Jacob. Absolutely. So my name's Robin. I'm a lived experience partner with National Voices. I had a spinal cord injury 17 years ago, so I'm disabled. I have 24-hour care and I have some fairly complex health needs encompassing both physical and mental health. The lived experience partners were involved in co-producing the roundtables events that led to this conference and the development of these 9 principles. We had opportunities to have conversations with organisations that we wouldn't normally have access to in co-producing the design of the roundtables. And it's so important that the voices of people with lived experience are involved in developing strategies and policies and the development of services that we use. We had some fascinating insights from members and panellists, as well as some frankly quite shocking statistics about the primary care workforce and the general levels of unsatisfaction and frustration from both the workforce and the users of primary care. These principles are incredibly important. Primary care isn't really fit for purpose currently. There's been much restructuring and there are pockets of initiatives and amazing work going on around the country, but we need to change the way that it's able to function and how it functions within communities in order to make a difference to everyone working in and using primary care services. Primary care is the front door of the NHS, as we all know, and it's so important to be able to personalise the services that we all encounter at that first step through the front door in order to improve patient outcomes, to make sure that services can meet people's wide-ranging needs and to see and treat people holistically. If we can get that first step right, then it supports people to understand their own health, to self-manage, to make informed decisions, and to reduce demand on other services. The continuity of care within primary care services is really important. At my GP practice, we stopped being able to book advance appointments when COVID hit, and we haven't yet been able to get advance appointments back. So when you ring on the day and you can get an appointment on the day, having potentially spent an hour on the phone, and then got through to receptionist and established whether you need to see a nurse or a GP, you get told that you can see this person at this time and no options if that's not the person that you're trying to see. So being able to see the same person for a follow-up or for the same problem would be wonderful, if only to save time having to re-explain the issue, my health, what we've tried, what's worked and what hasn't worked. And it's essential for anyone with long-term health conditions or with complex or multiple health conditions that if you're not able to see someone who knows you, that the health professional that you're talking to at least has oversight or an idea of the health conditions that affect you. Health professionals are busy people. They're not expected to remember everything about every person they've seen in the last 6 months. But some degree of familiarity goes a long way in not having to explain every convoluted step towards a diagnosis or in managing or treating a multitude of long-term conditions. I'd love for every health professional that I see to be able to have an idea of who I am and how my health conditions affect me. But the reality is that people in primary care don't currently have time to read care plans ahead of seeing people. The ability to have a coordinated review of multiple long-term health conditions is not something I've ever had, and it's something I'd really welcome. I have an annual medication review with a pharmacist, but that's just a 10-minute check that my repeat prescription list is up to date. I'm on a fair amount of medication, some of which means that my liver and kidney function is supposed to be checked every 6 months or so, but that doesn't happen. And we discovered recently that my most recent blood results that my GP had seen were 2.5 years old. It would be amazing to have coordinated, joined up reviews to look at multiple conditions in one go, not only at physical but at mental health together, and include a holistic approach to wider social needs too. And that include me as a person, not just as a list of diagnoses or conditions that need to be treated. Primary care has an opportunity to have a unique oversight of patients and to provide proactive care within annual reviews, whether that's with a GP or with a multidisciplinary team approach with a health coach or a link worker, a pharmacist, a care coordinator, an advanced clinical practitioner or a mental health practitioner, whoever needs to be in the room for that person. Ultimately, people living with long-term health conditions tend to become experts in their own conditions and in how best to manage their health within their own unique circumstances. But we need to recognise that, and we need to remove some of the barriers that currently exist to make it harder for people to manage and coordinate their health and ensure that people receive personalised, holistic and timely support when they need it. National Voice's vision for the future of primary care and the implementation of these 9 principles is key to doing that. And we need the primary care workforce and services to be supported to work differently. Thank you.
Thank you so much for that, Robin. I mean, your reflections on continuity of care, so important from a patient perspective. And actually, the fact that no advanced appointments are still not available in your practice. I mean, it's one of the constant frustrations we hear about. I understand why it happens from a practice point of managing demand. At the same time, it's part of the reason why we're in the crisis we're in, is that processes of managing demand are not actually meeting demand in any way. And so thank you so much for those really rich reflections and for your contribution in the work. So thank you. Our last speaker is Rachel Brennan, who's Participation and Progression Director at Groundswell. So Rachel, over to you.
Thanks, Jacob. Just to introduce Groundswell, we're a homelessness charity that work nationally, but we're sort of based in London. And we really believe that homelessness and health are inextricably linked. So all of the work that we do with people with lived experience of homelessness is around working with people to create, co-design and deliver solutions, not only to homelessness, but also to health inequality. I firstly just want to start by saying that we really welcome all of the recommendations in the proposal. these are things that we hear all of the time. We do participation work across the UK with people who have or experienced or are still experiencing homelessness. And so much of what's recommended is what we hear directly from them about what would help them to better get their health needs met and access and engage. I was just thinking about, and Robin, completely agree with everything that you've said. I was nodding along furiously, and just really wanted to emphasise, I suppose, the last point about working in partnership with people and communities. This is why it's so important. You need to hear directly from people around the impact of not being able to get health needs met and the impact of some of the things that we're talking about today. I suppose one of the things that I really wanted to focus on is the proposal number 8, really thinking about GP registration. It's such a huge issue for people experiencing homelessness. And it has been. I've been working in homeless health for 10 years and we're still having the conversation about GP registration, and it's, you know, really frustrating. Unfortunately, in the last 2 months, there's been two articles. So there's a Health Watch Haringey report about people with experience of homelessness and from migrant populations being refused registration at multiple GP practices in that area. The HSJ also did an article last week where they mystery shopped 100 GP practices in London, and 2/3 of them refused to register people. So still really important. And actually, unless, you know, people with experiencing homelessness are able to register with a GP practice, it's really hard then to think about how the other principles would benefit them. I think we've shown actually that, you know, the NHS has backed a campaign that's been directed at people experiencing homelessness. I just wanted to share a bit of a tool. So we've got these right to register cards for people experiencing homelessness, which are given to patients just to really clearly outline their rights to register. During the pandemic, the NHS sort of rolled out this initiative nationally, and these cards were sent out through Partners at Homeless Link to multiple member organisations, and yet we're still hearing of people being refused. So we've done lots of work over the last few years to work with people with lived experience, but also key partners from the homelessness sector, from health delivery organisations, but healthcare commissioners, really to think about some of the things that we think need to happen to make sure that we can really meet this sort of proposal in Principle 9. And some of the things that have come back are really sort of locally led, so thinking about GP practices and primary care networks. Actually, where's the good practice in that area? We know that homeless and inclusion health practices are able to register patients without proof of address and proof of ID. So how do they do that? Let's understand some of the barriers that people face, you know, that's leading to this registration refusal, and look at how we address that. And the big thing that it comes down to is training. There's no real standardised training for receptionists. You know, they don't really necessarily understand what their rights and responsibilities of the patient are, and the responsibilities of the NHS to register people without proof of address and proof of ID. And sometimes that's because the guidance is a little bit confusing. So we would really call on NHS to be able to, you know, really simplify this, and to back a national campaign that's not aimed at the patient, but that's aimed at the GP practices. And, you know, we really believe that if you can get this right for people experiencing homelessness, you can get it right for everyone, which is why, you know, we believe that it's really important. And when we talk about the training that people need, it's also about recognising the impact and the consequences of people not being able to register with a GP practice. So the impact it has on the individual, how it can make them feel, you know, really neglected, frustrated, that they don't trust the NHS service, and that can have a huge impact on how they access care in the future, which can have a huge impact on the NHS as well. But some of the things that people are asking for shouldn't be too difficult. Some of it is just around, you know, being compassionate and being friendly and really explaining to people why things are happening in the way that they're happening. And really thinking about some of those kind of barriers that are put in place, like, you know, the online GP registration, where you can't continue if you're you haven't got an address to put in there, but also training around how to speak to people about their homeless situation, asking for proof of address and proof of ID, and when it's appropriate to do that. So I think there's lots of work that underpins all of these, but I really do believe that they can happen, but they won't happen unless we all work together. So really, I suppose, you know, thinking about number 9, we need to sit down, we need to find the solutions that will drive forward some of these changes by working with the people who are impacted by them. That's it. Thank you.
Thank you, Rachel. And that registration issue, an important one, very close to my heart, having worked on it when I was at Health Watch England. And I've seen in the chat a number of local Health Watch people saying that they're handing out the right to register cards. But yeah, it's a constant effort, isn't it, to keep on and challenge that understanding of that rights to register in the NHS. And I know from a personal perspective, I've had to explain to 2 separate GP surgeries I've been registered with in the last few years, with people who stood next to me trying to register, being asked for proof of address and struggling. So, you know, it's an ongoing mission, but we'll only get there by working together with patients and professionals to tackle those sorts of issues. Right, we're going to move on to the Q&A section now. We've got about 15 minutes, I think, before then we wrap up. So I'm going to ask my colleague Pavi. Pavi, are you there?
I'm here, yes.
Would you like to, you've been monitoring the chat for us, haven't you? And you've got a few questions, is that right?
Yes, I have. The chat's been quite active, so it's really lovely to see everyone sharing their experiences and examples from their practices, etc. We've had quite a few questions come in, so let me get started with the first one. The first one is a reflection on the vision itself. How do we ensure that in revamping access and triage, we put user experience at the heart of this and include inclusive user experience? This has been sorely missing till date.
Okay, thank you. Does the panel, does anyone want to come in on that straight away, or do I have to do the job of picking someone to go first?
I mean, I can come in a little bit on implementation, although, which is to say, I think implementation of access solutions and tech solutions is a huge issue for practices. It is really important, clearly, that they work with their communities, but the skills and the headspace to do that are lacking. And so they're going to need support. And I think that's for local healthcare systems to really think about how they can use the expertise available to them locally to support practices to do this, because asking small practices to do that by themselves is probably not going to be the best solution.
Is that a role, Becky, you think, for the PCNs or for the ICSs in terms of the support they now provide to primary care?
I think it's probably the role for ICSs. I mean, that kind of expertise does exist around in the system. It might be in a hospital, it might be in the voluntary sector, it might be in local authorities, but it's about being able to draw on that expertise and that help to really think about how to make best use of what we know about inclusive user experience and to work with patients and users. It doesn't happen by accident. It will need external support to make that happen, I think.
And Rachel, I wonder if you want to come in on this, because obviously the community that you're representing, they are everywhere across the country, but often sometimes people struggle to think about how they engage the homelessness community and in these discussions. What advice would you have to anyone who's thinking about redesigning triage to work for the sorts of people that you're representing?
I would say use the guidance. There's now brilliant NHSE statutory guidance on working in partnership with people and communities. I think what the challenge is to make that, you know, not a broad brushstroke, but think about where the marginalised populations are. But it really can be applied to working with everybody. I would say the biggest asset that any community has is the voluntary sector organisations that are working with the people that you want to engage with. They have the trust, they have the relationship. But recognising any sort of involvement or participation work needs resourcing. So whether that, you know, is paying those organisations for their time to do the engagement work that you want to do, or to pay them to support the engagement work. I think the big thing in terms of engaging people around a topic as well is starting with what you know. So, you know, a bit like Robin said before, patients don't want to keep repeating their story all the time. Well, nor do they want to be asked the same question over and over again without seeing the change. And being really sort of open and transparent with people about why you're asking them, what their involvement is, making sure that you're managing expectations and what they can impact, but also keep up the communication. I think it's one of the things that we struggle with quite a bit, is that people want to get insight from people who've had experience of homelessness, then we never really find out, or it's hard to find out what happens with that afterwards. So I would say, yeah, they're sort of big lessons from involving anybody in anything, really.
Thank you. That's really
Jacob,
helpful.
Jacob,
Yes.
can I come in there as well? So I think the other thing about the digital implementation of services, primarily we've seen them traditionally, I think, through general practice, but I do think there is something about that knocking onto other parts of the primary care system. So, you know, the GP practice that, you know, my pharmacy sits next door to implemented Clinic, an online sort of service, but we then got lots of questions around what that meant for people who were struggling with access, because the pharmacy, you can walk in, you can have an appointment. So we actually arranged a training session for some of our team to understand what Clinic meant who weren't registered at those things. So we then have a process. We've sat down and filled in the forms for people and just sort of tried to educate them through. So I think if you are inclusive around that digital transformation around other primary healthcare providers as well, and explaining when that can go live. And, you know, I quite frequently walk somebody to reception and go, you know, this person's really struggling with this form. We now have an agreement that the care navigator team, the reception team, can help them with that form. So it affects not only the people using that when you change the system, but it also affects the other parts of primary care that support the people in that community. And I think that joined up approach works quite well. So I just wanted to highlight that. Thank you.
Thank you, Nick. That's a great example, and just it reflects back on, from a user point of view, it's all the NHS, you know, so why isn't the pharmacy able to help me with the thing that the GP's implemented? It makes perfect sense that you would, but that won't be a universal experience, I'm sure. So thank you. Pavi, can we get another question, please?
Yes, there's been lots of talk about sharing good practice between pharmacies, between practices, and even between ICSs. Is there any reflection, do the panel have any reflections about how we can ensure that good practice is shared across the country and we can move towards more equitable healthcare?
Nick, do you want to come in?
Yeah, so I can try and give some practical examples. So the NPA amongst our members holds something called an Innovators Forum, which is for our members, where we actually ask people connected not only within England, but across all 4 nations to regularly share best practice. We also have an organisation which is called Community Pharmacy England in England, where they ask of any local innovations to be shared nationally. I think then it's about us as a sector for sharing good practice, not be so in the day job and actually raise our head above the parapet. How do we share good practice? So engagement in conferences like this, engaging with people that use the service, I think is key. So we have got some pockets of where that's shared, but I think it could be better. And places like this conference is a great place to showcase that, really importantly with the people that use them, and not just the echo chamber of our own individual silos. So yeah, I welcome the opportunity. Thanks.
Thank you, Nick. Portia, I wonder if you had any thoughts on this in terms of any ways that you share good practice, particularly in stuff about we talk about the diagnostic pathway, anything that you do around promoting good practice across the sector to support your members.
So what we are doing, Jacob, is we are bringing together different patient charities, so not just our own, but across the lower gastrointestinal conditions, with clinicians to coordinate a response, to coordinate that pathway, so that you know, regardless of what condition you might have, you still get that same quality of care that you need. I mean, it is still kind of a work in progress, but the way that we think we will be able to get it, you know, make it stick is by having kind of the buy-in from, you know, the most of the population. We are kind of talking about 1 in 2 people across the UK who are being affected by these conditions in total, and that is a kind of a stronger case for ICS to make an implementation of the new pathways.
Thank you. Pavi, another question, please.
Yes. Carefilla's report emphasised both access and continuity as being important. But as we're moving forward into the implementation phase of the report, there seems to be a much greater focus on recovering access, and it seems that we're losing focus on personalised care. How do we ensure that that's not lost?
That's a great question. I'm going to come to Robin, if I can. Robin, because you talk so eloquently about personalisation and sort of the continuity of care angle. Do you have any thoughts on how we make sure that we don't lose that in the rush to just recover access? How do we keep hold of that personalisation element?
I think working with people with lived experience to develop how services are produced and how they go forward is certainly a really good step. And I think, yeah, I think keeping people at heart and ensuring that the ability and that the workforce is supported to be able to provide personalised services and tailored services that keep people at the heart of what they're trying to do is vital.
Thank you. Anyone else want to come in on that question? But I mean, Rachel, you look like you're trying to go.
Yeah, sorry, I'm putting my physical hand up, which I'm sure isn't very helpful, Jacob, with this many people on the call. I think it's linked into one of the other principles and thinking about that holistic support. Like continuity of care and personalisation doesn't just have to come from the GP or the clinician or whoever it is that you're seeing. And certainly at Groundswell, one of our strengths really is our peer support service. So we have a setup which is now sort of been adopted by other organisations on a national scale, a homeless health peer advocacy project. So clients have a peer advocate who's that shared experience of homelessness and, you know, other sort of multiple disadvantages. And they build the relationship with that person, and that person helps them to support and navigate the healthcare system, supports them to build confidence and skills that they need to be able to navigate the healthcare system independently. And we've really seen, I suppose, with the ICS and PCNs, how like the ARSS roles can be utilised for that. So we're trialling in London where those roles, how people with experience from inclusion health groups who sit within the GP practice and work with marginalised populations in that area. And I think we've got a real opportunity with lots of those kind of community and PCN based roles where the relationships, the trust can be built outside of the sort of traditional clinical setting, but can support people to still access, engage and navigate to get their health needs met.
No, thank you, Rachel. I mean, the point about peer support is incredibly well made. I was speaking to a colleague from Compassion in Dying the other day about the peer support program they've been running. About actually the evaluation they've done has shown it helps people prepare better for appointments. You know, they feel better able to ask questions, more empowered. They feel like better able to consider their options for treatment and what the effects might be. And actually, there's all sorts of different ways that peer support could be used to support that interaction with primary care and also support the continuity angle. So I think it's again, it's a much underexplored area in the system, but really important. Do any of the other panelists want to come in on this continuity question and how we maintain that in the against the sort of the pressure to just focus on access?
I mean, I guess from thinking about team, just to build on that point around team continuity doesn't necessarily mean one person, but it does require the whole team to really share the information. I really like the concept of micro teams, little teams of a combination of different staff who know a group of patients. So you can talk to any member of that team who know your story, know what you need, and can look after you as a team. I think that's really key. And also that continuity matters for people at different points in their lives. So while you might not always need continuity, when you're going through an uncertain process of diagnosis, for example, you really do need continuity. So better systems to be able to enable that when you really need it, it is really important.
So Jacob, I'd just build on that as well. So, you know, a community pharmacy is much more than the pharmacist. You know, I sold a pharmacy business in Newquay, but the lady that worked there that, you know, was the first people most people saw held me when I was 2 days old and I'm 47 and is still working in that community pharmacy. So, you know, I think that recognition of the team, I think is really important. And when we can, that welcome and that greeting face is really important. Because it really affects health outcomes if you're trusted, you know, things like vaccine hesitancy, advice, you know, those things are really important. And again, for those people that aren't registered maybe with a GP provider, that catch that the community pharmacy can do with a regular and friendly face, I think is really important.
No, thank you. Just that there is so much about just that's the first point of contact and the trust that you have that you build over time. And as you say, the vaccine hesitancy thing that came through very strongly in the pandemic, that people trusted advice from people that they knew in their local health sector. So really important. It does lead me to think though that continuity, we often talk about it only as the people. Do we think there's any potential in technology to support continuity of care?
So if I would go with that, I think that's a really challenging question. I think, as with all systems, a personal point of view, I guess technology, if it gives you the outcome and you trust the outcome, could give continuity. You know, I know if I order my Domino pizza, it's going to come, which is probably why I look the way I do and need to think about my food choices better. But that does give me some continuity in outcome. I don't think it gives you the same level potentially of compassion and stuff, but I think there's an interesting thing about continuity if you're looking for a transactional outcome. But so much more of healthcare is more than transactional, would be my personal view.
No, I think that's helpful and really adds to the, if you trust that the tech and the admin's going to work, it can also help you build confidence in the relationships you've got with people, and that works for staff and for patients. Paddy, we might have time for one quick last question, and then I'll do a wrap up.
In which case I might combine my last two questions. There's been a lot of conversation around sort of the use of wider roles within primary care and general practice in particular. How do we ensure that staff within general practice are aware of everything that's available to patients, and also ensuring that sort of reception teams, for example, are able to make sure that patients have access to and are signposted to all of the services that are available to them?
I might come to Rachel on that one, given the registration thing is often the reception thing, but building out from the idea, how can we help make sure the staff are aware of all the guidance that you talked about?
So I suppose the training that I mentioned, but one of the other things that has come up a lot when we've done lots of kind of participation workshops with people with experience, but also people working in practice. So I appreciate that this is for homelessness, but I know from previous work in GP practice that you do have within teams like cancer champions and additional roles like that people take on, but having something similar for homeless and inclusion health groups, so that you're investing in somebody to have that knowledge, to understand and to be able to pass that knowledge on to other people. And I suppose going back to those additional roles within primary care as well, I think a lot about, you know, one of the things that we hear quite a lot is actually the first contact in services. We did some workshops in Wakefield last year, and that was one of our focuses really, and everyone was kind of saying actually the best place for the first contact with services is to happen outside of the service, that you're building that relationship and then inviting people to come into the service with you. So I think it's just about rethinking how we're delivering services really, and how we're engaging with people, and that is some really good examples of how that works from homeless and inclusion health practices. You know, we've got kind of clinicians doing outreach, we've got, you know, other sort of link worker roles doing outreach, and that's been the sort of model for years. We've now got this opportunity with primary care networks and the additional roles that primary care networks can employ, which does have more of a focus on outside of the practice, which, you know, thinking about what, you know, Becky was saying before about the pressure on GP practices, that isn't just sort of pressure on numbers, it's also, you know, huge pressure on space. So that was a, you know, huge problem for the GP practice I worked in, is that they just didn't have the space to deliver the services they need to. So actually, you know, that's something that could, you know, have multiple sort of benefits really, if you think about delivering in a different way. And thinking about what Nick was saying about like community pharmacy and like all of the things that you can do, again, that's a huge thing that's come up from our sort of lived experience members around, you know, they have, all of our research has shown that, you know, community pharmacists and paramedics came out really high on engagement. So actually, how can you utilise that relationship and be able to provide more? Again, through the pandemic, we heard, you know, that kind of continuity that people had with their pharmacists, but they weren't having with anybody else, was really important to people. So I think we need to listen, reflect on that, and then really think about how we can then change delivery to sort of, you know, meet what people are asking for.
Thank you, Rachel. Panel, we are almost out of time. Any final reflections before I wrap up? Anyone wants to come in on that last question?
So all I would say, Jacob, is you know, primary care is a team, it's a wide team, and that sort of making sure that you give the right advice, you know, whichever part of the primary care team you're sitting in, whether that's dentistry, dental practice, community pharmacy, wherever it may be, is quite hard to keep on top of. But I think that knowledge of what's around, and actually listening to people feedback. So, you know, if you're signposting somebody, they go, that worked really well, that didn't work really well. That lived experience of the people that are actually accessing that service, I think is key when we're signposting. And I think it's just the recognition, you know, all parts of primary care need to be updated when things, systems, pathways, whatever we want to call them, change, because at the end of the day, it's the person accessing that care that is affected by that. As much as the healthcare professional, no one wants to give duff advice. So I think it's just making sure everything kind of links together. Thanks, Jacob.
Thanks, Nick.
May I just make a very quick point about the reception? So one of the things that we found out in our talking to people with lived experience of Crohn's and colitis was that about a quarter would simply not go to their GP because they would be too embarrassed discussing sort of their toilet habits and bowel problems with the receptionist. And we heard quite often that they are being kind of brushed aside, or it's probably something you have eaten, it's probably your kind of lifestyle, etc. So people just not being able to make an appointment because of it. So one of the ways we kind of tackled that is providing a symptom checker and a letter that they can people can take to their GP surgery, including their pharmacist, which kind of tells them, including the receptionist, which tells them, you know, a independent organization, expert organization have advised that this person needs, you know, an urgent appointment, that this can no longer wait. And it's that I think there is and a lot of other patient charities do this as well, and I think there's a role for patient charities to support individuals to communicate the urgency and you know, and break taboos for subjects that are proving to be a barrier for interaction.
That an excellent example and a really practical thing for VCSE colleagues on the call to take away about things that we can do to help staff understand the range of options that help patients. Robin, you've got your hand up. It's fitting that as our lived experience partner, the last word will go to you before I wrap up. So, Robin.
So 2 quick points. I think the more that we can link primary care into everything going on within the community and all parts of primary care into the local communities, the better. And also, you know, training for front of house staff in all primary care services in terms of being able to help signpost people to move away from the idea of receptionists as gatekeepers and more as care navigators and linking people into the services that are available, the better. And there needs to be a huge shift in the public perception of front of house staff within primary care and in the training that they can receive in order to help people navigate their way through the system.
Thank you, Robin. Excellent point to finish on. So I'm just going to wrap up very quickly. So just in terms of themes, we've covered an awful lot in this discussion, but just some of the things that I've heard and I'll take away. First theme about purpose and our focus. I think in primary care space, we heard about actually we're not put enough focus on moving care into the community. We need to actually the system needs to put its money where its mouth is and actually move in that direction. And that's going to require some teamwork with, I think we've just talked about with the skill mix in practices. So receptionists working with pharmacists, with GPs to make sure we've got the right skills in the team, and also the role that the voluntary sector can play in that team in providing advice and information to patients. So that's the second theme about that skill mix and team working. And then the last theme for me that really came through very strongly was the role of co-production and working with patients to understand what's working and what's not, and for that to be a continuing process, and to keep communicating with patients when we've changed things, explaining what we've done, why things have changed, and listening to make sure those changes have actually helped people. So yeah, a huge amount covered, some really useful themes pulled out. I'd just like to say a big thank you to all of our speakers for taking part. There is also a link in the chat, and if we can post it in the chat again, to the report behind the principles for the vision, so you can go away and read it in more detail. I'd also like to take a moment to say thank you to our sponsors for this session, who made it possible. So Astra Zeneca, who provided the sponsorship grant towards our independent programme of work on the future of primary care, and Diabetes UK, who provided the funding to support co-production for our work on this vision. So thank you to the sponsors, and also thank you to the members of National Voices and our lived experience partners who helped us create the vision. In particular, Robin, thank you so much for taking part in the panel, but all the work you've done on the vision. Also, Louise Woodward, who will be speaking on a panel later on, played an important part in the development of this. So thank you to Robin and Louise.